Hello, everyone. This is Dr. Vidhi Babar. Today, we are going to discuss a very high yield topic of USMLE Step 2 and Step 3, which is approach to thyroid nodule. And I'm sure that after watching this video, you are going to solve all of these questions correctly. And let's dive into the topic. So, our topic is approach to thyroid nodule. So we all know that they almost always ask about the best next step. And today in this video, we are gonna learn like how to select the next best step for thyroid nodule management. First of all, we will start with a question, as this is an ideal method to study for USMLE Step 2 or 3. A 47-year-old woman presents for evaluation of a thyroid nodule that she noticed while looking in the mirror. She denies dysphagia, hoarseness, weight loss, heat or cold intolerance, or prior radiation exposure. Physical examination reveals a firm, mobile, solitary 2.1 centimeter thyroid nodule without cervical lymphadenopathy. Lab studies show a normal TSH level. What is the best next step in the management? So, what about option A? We check serum calcitonin for the recurrence of medullary thyroid cancer or for the surveillance of medullary thyroid cancer after treatment, right? So this is not the right option. Radionuclide scan, we perform this investigation to differentiate hot nodule from cold nodule, and we are going to select this option if the TSH was low, or if we had the suspicion of hyperthyroidism. Then we will select option B. We will come to the option C later. But what about option D, which is a very tempting option here? Now, the option D directly, just on the basis of TSH, would be a little invasive, and we need we need an investigation before getting FNA. So the correct option here with normal TSH level and without any symptoms is option C, and ultrasound is gonna dictate us whether we are gonna need FNA or whether we will go with repeat physical examination in 6 months. So now let's discuss how we how we came to the conclusion that option C is the correct option. Now we will learn in detail how to choose the next best step in the scenario of thyroid nodule. This is the whole algorithm. I will try to make it simple. Whenever a patient comes with thyroid nodule to you, the initial evaluation is going to be TSH and thyroid ultrasound. Now you are going to write in comment whether TSH is preferred or thyroid ultrasound is preferred on the first step. Yes, TSH has more importance than ultrasound here. So whether you can get TSH level or you can get both on the initial step. After that, the further step is gonna be decided by TSH levels. If TSH levels are normal or elevated, then we are gonna perform thyroid ultrasound. If the TSH is normal or elevated, if the patient is euthyroid or hypothyroid, the next step is going to be thyroid ultrasound. On the other hand, if the TSH is low, if the patient is hyperthyroid, then we are going to perform a radionuclide thyroid uptake scan. This scan is going to differentiate whether the nodule is hot or cold. If after performing radionuclide scan, nodule is cold, then we will perform ultrasound if we didn't perform it at the first step, right? and ultrasound will decide whether we need FNA or not. And if the nodule is hot nodule, hyperfunctioning nodule, the radionuclide thyroid uptake scan is showing increased iodine uptake, then it's hot nodule. And hot nodule are rarely malignant. We do not need FNA. We are gonna treat the hyperthyroidism using anti-thyroid drugs. Now I'm coming to the this arm. So TSH normal or elevated, we will perform thyroid ultrasound, and ultrasonic features of the nodule are going to decide whether we need FNA or not. So if the suspicion is intermediate or high, we will perform FNA. If the suspicion is low or benign, we are going to repeat ultrasound in 6 to 12 months and interval based risk on pattern and size. So this is the whole algorithm that will decide the whole management of thyroid nodule. Some students make mistakes here. They think that a certain size of lesion on question, size of nodule on lesion will dictate whether we need direct FNA or not. I have taught students that, and I have encountered many wrong concepts in students. Like for example, some consider that if the size is greater than 2 centimeter, then we are not gonna need ultrasound, right? They directly move towards FNA, which is wrong. Which is wrong. First, whatever the size of lesion is, first we are gonna get TSH level, and next step, if the TSH is high or normal, then if the TSH is normal or high, we are gonna perform ultrasound first. Always ultrasound before FNA. And if the TSH is low, then we are gonna perform radionuclide scan. Again, first step is gonna be TSH. Next, if TSH is normal or high, we will perform ultrasound, and ultrasound will decide whether we need FNA or not. And if the TSH is low, we will go for thyroid radionuclide scan. So some high yield pearls that I'm going to discuss, if the TSH is normal, we will perform ultrasound, right? If the TSH is low, we will perform scan before biopsy, right? And again, first measure TSH, ultrasound will derive FNA, always. And I will discuss some common pitfalls, some common USMLE traps. Biopsy before ultrasound is always gonna be wrong. It will be wrong. If you ignore TSH on first step, it would be wrong. If you use just size of the lesion, if you are gonna use just size of the lesion to decide whether we need FNA or not, this is wrong. So what are the features that are important to decide about FNA? So I'm gonna read some important highly malignant signs on ultrasound are solid hypoechoic, irregular margins, microcalcification, taller than wide shape, or extrathyroidal extensions. These are some ultrasonic features which carry high suspicion for malignancy. So this was the whole approach in thyroid nodule, and I'm sure that if you have watched all of this video till end, you are not gonna mark this question again. Thank you so much for watching the video. Let's meet again in our next video. Don't forget to subscribe and like our channel.